Good morning, everybody. I think it's time to start. First of all, I would like to tell everybody that if we will have time for discussion, and maybe somebody may not feel comfortable with the English, and if somebody wants to ask something in Spanish, we can translate those questions to the speakers. To English, so no problem. Just feel free to make questions if you have any questions. Okay, let's start this round of talks with the first one that is by Dr. Eduardo Marban, and he's going to talk about biological therapies for cardiac arrhythmias.
Good morning, everyone. So you all know that arrhythmias can be made worse by drugs. That radiofrequency catheter ablation can be curative in certain settings, and that implantable devices can work very well, but they involve a number of procedures and expense and potential complications. So we considered the possibility that some kind of novel therapy involving treatment with genes, cells, or exosomes, and I'll explain what exosomes mean later, might be efficacious in either the treatment or the prevention of cardiac arrhythmias. So several groups including ours, have probed different disease indications for biological therapies, and they're denoted here. The ones I want to focus on today are bradycardia, so the creation of a biological pacemaker as an alternative to electronic pacemakers. And then I'm going to tell you about new work that we've done to use exosomes to create a biological ventricular tachycardia ablation. So the first of these goals is the biological pacemaker, and the rationale here is that in certain populations, for example, patients with hardware infections or in utero congenital heart block, have a demonstrable clinical need but have a contraindication or impossibility of getting a pacemaker. This biological pacemaker could be hardware-free and would leave the possibility of doing only focal genetic manipulation, for example, if you put in a gene. It's easy to quantify the efficacy just by taking an electrocardiogram or measuring the pulse. And if you create a biological pacemaker and it's too fast or too slow, you can potentially rescue it using traditional ablation methods. So I don't need to review for this audience the normal pattern of cardiac conduction, but let it suffice to say that the conduction system, when isolated from atrial muscle or ventricular muscle, can cause electrical standstill. And when you measure the electrical signature of the various cellular action potentials in each region of the heart, you can see that the ventricular myocyte has a very polarized, hyperpolarized resting potential, is not automatically active. It doesn't have this spontaneous phase 4 depolarization. But one thing we might try to do is to take some portion of the ventricle, for example, the area in the septum around the His bundle, and convert it from a ventricular phenotype to a sinoatrial node phenotype, something which can easily be done in PowerPoint, but in biology, we sought a way to do this. So one way that we devised and we published in 2002 is to use a genetic vector to knock out one of the potassium channels of ventricular muscle called KIR 2.1 by creating a poison pill dominant negative construct that would multimerize with and cripple the healthy products of the wild type allele for this channel, KIR 2.1, which encodes an ionic current called IKR, which is an electrical brake. So the idea was if you remove the electrical brake, you might liberate pacemaking activity. And in fact, that's what we found. This is what a myocyte looked like from the heart that was transduced just with a reporter construct. It's had to be stimulated here, otherwise it would have been a flat line. and the EKG from such an animal was typical. On the other hand, if the animal received this poison pill construct for KAR 2.1, we liberated, this is within ventricular myocytes, we liberated pacing activity, and now we saw idioventricular activity in the electrocardiogram. So we then went on to use stem cells and hybrid gene and cell approaches. But what I'm going to tell you today is sort of our favorite story, and that is somatic reprogramming. Here we can actually take one kind of cell and convert it into another kind of cell. And specifically, we're converting a ventricular myocyte, of which there are 5 billion in the human heart, to something that looks like a pacemaker cell, of which there are only about 10,000 in the human heart. And how do you do that? Well, we took a clue from embryology. We know that as the heart is looping and the region that goes on to create the sinoatrial node is beginning to be formed, a number of transcription factors are transiently expressed in this area, and then the area for the rest of the life of the person or the mouse or whatever mammal is studied persists as a sinoatrial node. So we wondered whether re-expression of one of these transcription factors in the adult ventricle might suffice to convert a ventricular myocyte to something that looked like a sinoatrial node cell. And indeed, we reported this in 2013. This is what a normal sinoatrial node myocyte looks like from a guinea pig. This is what a normal ventricular myocyte looks like in a guinea pig, much larger, definite striations, rectangular shape. But this is what a ventricular myocyte looks like a week after it was transduced with an adenoviral vector containing the transcription factor TBX18. So basically, we've converted a cell that looks like this morphologically into cells that look like this. There's actually 2 cells there, both of which are spindle-shaped. Electrically, we did something similar as well. So here's a real sinoatrial myocyte. It's sinoatrial node pacemaker cell. It's firing spontaneously. Here's a real ventricular myocyte that's just transduced with green fluorescent protein. It's just a control. And this is a typical ventricular myocyte. The action potential is triggered with electrical stimulation. Otherwise, it's silent. But if the myocyte instead had been transduced with TBX18, it liberated endogenous activity. So electrically and morphologically, we've converted ventricular myocytes to sinoatrial node cells. So can we do this in vivo in a clinically realistic model? For this, we used a MyoStar catheter, which is compatible with NOGA mapping. And we can selectively inject areas of the heart after mapping them within the magnetic field using NOGA techniques. And we came in to the right side, so it's a low-pressure system, and injected in the high septum to try to create basically His bundle pacing. And in so doing, we were able to create a biological pacemaker in a pig model of heart block. The pigs that received only a reporter gene remained close to the backup pacing rate of 50. There were some escape beats, but the overall rate was low. And the rate was about 15 or 20 beats per minute higher on average in animals that had received TBX18. The dependence on the electronic pacemaker was also significantly less in the group that had been injected with TBX18. And if we looked within the area of transduction, we could find within the high ventricle these spindly-shaped cells that looked very much like sinoatrial node cells that would never be found in this area without having been transduced with TBX18. And likewise, we found evidence of TBX18 messenger RNA and a molecular signature of sinoatrial node cells in this region of the ventricle, where ectopically only would you find a node-like phenotype. So there still remains some unanswered questions. One is, can you get persistence and long-term biological benefits? So I'm going to show you 2 new protocols, one in which we use TBX18 His bundle injection and just follow 2 months, and the other one in which we allow 1 month of right ventricular pacing to occur, the development of something like a right ventricular cardiomyopathy, and then do His bundle pacing as a rescue protocol. So in the first prevention protocol, we find that indeed if you just follow the animals, you get a sustained benefit for 2 months in heart rate, and also in backup pacemaker utilization, a much lower rate of backup pacemaker utilization in the TBX18 animals than in GFP controls over 2 months. What about the rescue protocol? If we induce heart block and then wait 4 weeks, we find that, yes, at that point we can increase the heart rate and decrease pacemaker utilization. And I'm not showing you the data, which are coming out soon in the Journal of the American College of Cardiology, but there was an improvement in ventricular function associated with this rescue electrically. So for the biological pacemaker, I've shown you some novel alternatives to electronic pacemakers, specifically somatic reprogramming to convert ventricular myocytes to sinoatrial node-like pacemaker cells, and a method for clinically realistic percutaneous delivery into the atrioventricular junction. So next steps towards the clinic would be animal testing with clinical grade vector, regulatory filings, and a phase 1 clinical trial. And among the indications that we're considering to develop this first-in-human therapy would be a bridge to device in a pacemaker-dependent patient that has a hardware infection. So during the time where we typically take out the hardware, give antibiotics, and put in new hardware to use a biological pacemaker as a sustaining vehicle rather than a temporary transvenous pacemaker. And the other indication, of course, is intrauterine delivery of the TBX18 to try to save infants with congenital AV block resistant to steroids and potentially fatal hydrops fatalis. So let me tell you about the second story, and that is to develop a non-destructive alternative to VT ablation. I don't need to belabor this with this audience, but the treatment of ventricular tachycardia with recurrent ICD shocks, sometimes called electrical storm, is extremely difficult, especially in cardiomyopathy patients, and reentry is the most common mechanism of VT in these patients. Catheter ablation can selectively destroy bundles of viable myocardium to interrupt reentrant pathways, but sometimes carpet bombing of the ventricle is required to achieve some kind of control of the VT, and there's significant complications. It doesn't work that well. It destroys viable myocardium. You can get perforation, stroke, and left ventricular dysfunction. So our hypothesis was that instead of destroying slowly conducting pathways, perhaps an antifibrotic/regenerative strategy could improve conduction and disable reentrant VT. So how could we do that? Well, we took a lesson from the cell type called cardiosphere-derived cells that we've been developing for other reasons for cell therapy. It's a human heart stromal cell with characteristics that are unique antigenically. They've now been involved or used safely in 11 clinical trials. And in those 11 clinical trials, the ones that have been finished, there's been not only safety, but some signals, preliminary signals of efficacy in various diseases ranging from post-MI ventricular dysfunction to hypoplastic left heart syndrome to Duchenne muscular dystrophy. And we understand these cells to work not directly by stem cell-related effects, but by paracrine effects. They secrete something which promotes cardiomyogenesis, prevents apoptosis, and more importantly for this indication with VT, they're antifibrotic and anti-inflammatory. So we could use the cells in principle, but they have a number of limitations. And now we can take advantage of the fact that exosomes are known to be the active principles of CDCs. What are exosomes? Well, they're secreted particles that are lipid bilayer vesicles about 100 nanometers in diameter. And just to put that in context, 100 nanometers is the diameter of an HIV-1 virus. They're present in all body fluids and are released by nearly all cell types that have been studied. and they're loaded with microRNAs and other bioactive contents. But not all exosomes are the same. The payload is very cell-specific and also very sensitive to the conditions under which the cells are grown. So some exosomes are bad and promote tumor metastasis, for example, and some other exosomes are antifibrotic and promote cardiomyogenesis. They look the same, but they're very different. So why are we interested in exosomes in the context of CDCs? Well, first of all, if we use CDC exosomes instead of the cells, we get a trophic benefit in terms of heart function. You can see this is ejection fraction after a myocardial infarction in a mouse. And on day 0, the animals received exosomes, not cells, just the cell-free particles. Ejection fraction went up over the next month, but if you put in vehicle or fibroblast exosomes, there was no benefit in terms of function. So exosomes themselves, in a cell-free manner, when injected into the heart, improve ventricular function after a heart attack. This shows that a normal CDC will also increase heart function over time, but if the CDCs are exposed previously to GW4869, a small molecule blocker of exosome biosynthesis, there is no benefit. So exosomes mimic the benefits of CDCs, and blocking exosome biosynthesis gets rid of the benefits of CDCs. If you use CDC exosomes, and we reported this work in the European Heart Journal a couple of years ago, and here we also used NOGA-guided MyoStar catheter injection. You can get a reduction in scar post-MI and an improvement in ventricular function. The reductions in scar are shown here by magnetic resonance imaging and also by comparison of 2 different hearts, one of which was injected with exosomes and the other was a control. So we then asked, can injection of CDC exosomes specifically into zones of slow conduction prevent ventricular arrhythmias? And so we implemented a protocol in which we randomized animals to receive either CDC exosomes or just the media, IMDM. And the first thing we did in these pigs was to cause a large myocardial infarction by 90 minutes occlusion of the mid-LAD. And then 8 weeks later, we did a magnetic resonance imaging at baseline with gadolinium enhancement to detect scar, programmed electrical stimulation, high-density electroanatomical mapping with Arrhythmia, and then NOGA-guided injection. 2 weeks later, we repeated everything, MRI, programmed electrical stimulation, high-density mapping, and programmed stimulation, and then took the heart out for histology and proteomics. So here's what the high-density Arrhythmia map looks like in a typical post-MI heart at baseline. You can see that there's this typical slow conduction pattern and isolated late potentials that can be seen in specific areas. And then if we take this very detailed landscape view and translate it to a lower resolution NOGA map, we can find these areas of slow conduction again and inject the biological material there. So when we do so, and we look before and after, animals that received CDC exosomes, such as this one, have less scar. You can see less white stuff, which is the gadolinium enhancement in the tissue afterwards. If you do a 3D rendering and a pseudo color, you can see a reduction in apparent scar within the ventricle. Scar mass was unchanged over time in controls, but decreased in animals that received CDC exosomes. And you can see the differences here between the 2 groups are significant. What happens to electrical conduction? Well, you can see here an example of one animal before and after, and you can see that there's less apparent inhomogeneity in the ventricle and also a marked abbreviation, if not elimination, of the isolated late potentials in the region of slowest conduction. And you can see that the late potentials in control didn't change, but were reduced in the CDC exosome group, and their timing was significantly different in the 2 groups. So what about the real story that we're interested in? Is ventricular tachycardia inducibility any different? So here we show typical data before and after in a control animal. And here, basically, we show how many extra stimuli are required to induce the ventricular tachycardia and whether the animals were inducible or non-inducible. And in this set of studies, 6 of 8 animals were inducible at baseline, and all 8 animals were inducible 2 weeks later. This is control injection. But animals that received CDC exosomes most often, went from inducibility of ventricular tachycardia or ventricular flutter to non-inducibility. And you can see that 1, 2, 3, 4, 5, 6, 7. 6 out of 7 animals were not inducible. All were inducible at baseline. 6 out of 7 were not inducible afterwards. Only 1 remained inducible. So it looks like quite a qualitative difference between the 2 groups. Now, we collaborated with Natalia Troyanova at Johns Hopkins. We gave her the images, and she predicted, just on the basis of the images, that the arrhythmias would be inducible at baseline and non-inducible after CDC exosomes in several of the treated animals. So to summarize, for biological Vt ablation, we found less scar after injection, and we actually are pursuing this as a potential indication. Thank you very much.
Can do questions after, right?
So good morning to all of those who enter the room later. And now we continue with this session, and we go to the next speaker, who is Dr. Roy John. And the title is Non-Invasive Cardiac Radiation for the Treatment of Cardiac Arrhythmias.
Good morning, everybody. It's been a pleasure being here. Thank you for the invitation. My task is to talk about alternative therapies for ventricular arrhythmias, and we're going to dabble a little bit in the non-invasive cardiac radiation treatment for cardiac arrhythmias. So we all know that implantable Cardioverter defibrillators reduce sudden arrhythmic deaths, and we have a lot of data. And a meta-analysis recently showed that this is usually a 30% reduction in overall mortality from a defibrillator, and that applies to both primary as well as secondary prevention. The trouble with secondary prevention ICDs is that the shock rates after an implant of an ICD is pretty high. On average, it's anywhere between 10 to 20%, depending on what series you look at. This data from 2013 shows that about 12% of patients will experience a shock within the first year after an ICD implant for secondary prevention. And we also know that the onset of therapies from an ICD usually means increased mortality. Just from ATP only, the hazard ratio for mortality is 1.46. For a single shock, it's about 2.11, and for multiple shocks, it goes up to 2.5. So clearly, devices are good for saving lives, but not particularly good for ventricular tachycardias because patients get repeated shocks. Now, there's been at least 3 randomized trials of catheter ablation for ischemic ventricular tachycardia. And all of them show a significant improvement in the VT rates compared to drugs. However, despite the improvement, you see that the recurrence rate is pretty high. On the right, you have the VANISH trial, which is the latest trial to be published, and that showed that compared to escalation of an antiarrhythmic drug, ablation was actually superior in terms of reducing VT. And this was primarily in patients who were originally treated with amiodarone, and rather than increase amiodarone dosing, if you went on and did an ablation, they had a better outcome. The problem with VT ablation, of course, is that the recurrence rate is anywhere between 30 and 60%. And on the right, we have a graph from a recent publication that we were involved in at the Brigham and Women's Hospital. And you can see that in something like 700 patients over a 10-year period, patients had a 60% recurrence rate, the majority being patients with non-ischemic, or the worst outcome being in patients with non-ischemic cardiomyopathy. And even patients with no structural heart disease had a recurrence rate, and their success rate is about 80% at 10 years. The reason why VT ablations fail is a lot of these substrates are intramural, and we have a few techniques to try and get into these intramural circuits. one of them being the use of half-normal saline. We've tried dual-site, unipolar and bipolar ablations. And we also, at the Brigham, we had the needle electrode. One of my colleagues, Dr. Stevenson, was the primary investigator for this. And the needle ablation protocol basically uses a catheter that you just saw, that's a Noga catheter, except that this one, we actually had the electrode. Do we have, yeah, okay, let's try this. Let's see if this works. Yeah, okay. You can see that the catheter actually has a dome electrode, a ring electrode, all insulated from each other, and a needle electrode, again, insulated from the dome. And essentially, you could map using the dome electrode, and once you found something reasonable, we would then go in and sink the needle, extend the needle into the tissue, and inject contrast to make sure you're well within the myocardium and not outside the myocardium in the pericardial space. And once you were there, you could then apply radiofrequency into the myocardial, intramyocardial delivery by delivering radiofrequency through the needle. And this is a typical patient with a laminin cardiomyopathy and a large scar involving the septum and the infra-aortic area. Here's the aorta and the mitral and tricuspid valves. And you can see that multiple areas in this areas were ablated previously. And with the needle ablation, we were able to render this patient non-inducible. Of interest, this is a patient where the patient actually has ventricular tachycardia inducible. This recording is from the dome electrode, which is actually on the surface of the myocardium, and you see no signals whatsoever. However, once you actually deploy the needle into the myocardium, you can see early diastolic potentials, which suggests that the substrate for this arrhythmia was actually intramyocardial. And by ablating within the myocardium, we were able to render this patient non-inducible. Even with a needle ablation, results are not fantastic. Remember, these are patients who have already failed previous ablations. And at 150 days, we had a success rate of about 50% in these patients, meaning about half of the patients actually had recurrence of VT, although a significant number of patients are improved clinically with the use of antiarrhythmic drugs. So total failure occurred in about a third of patients, but about 70% of patients actually had some kind of improvement. Now, needle ablations work in a significant number of patients, and we don't quite know where that particular technology is going to go. There is another needle that's also being developed whereby there is warm saline being infused into the myocardium, and radiofrequency is actually applied through the warm saline. That produces larger lesions, and it's again under investigation. So some of these needle electrodes might provide some solution to some of these deep intramyocardial substrates. The other thing we do when things get desperate is to do transcoronary ethanol alcohol ablation, and this is our data from the Brigham and Women's Hospital, which we looked at in 2012, and since then we probably have another 20 patients. And again, you can see that the success rate is about 50%. 50% of patients will recur. And especially in patients who have the first septal perforator taken out, these patients will develop complete heart block. And we have to usually end up upgrading the device to biventricular devices. So then comes along the role of radiotherapy for patients who actually have intractable ventricular arrhythmias, where nothing else really works. Now, if you look at the evolution of radiotherapy for disease processes, you can see that the use of radiation is primarily for malignancies, and it uses photons, X-rays, or gamma therapy used to damage tissue. And traditional therapy typically uses multiple daily fractions of about 2 grays over 4 to 8 weeks. And it became clear that, way back in the 50s, that for cerebral or intracranial tumors, you could use stereotactic radiotherapy using high doses of 16 to 25 grays in a single fraction and have a similar effect. This was then, extended to treat, there are reports of treatment of intracardiac tumors using stereotactic body radiation therapy, SBRT it's called. And this is the basis for people trying it out in cardiac tissue, modeling it for use in cardiac arrhythmias. These are some early studies using it to target atrial tissue in the porcine model published in 2010. And you can see that this basically targets the cavo-tricuspid isthmus. Here's your right atrium here, IVC here, and this is the mass of tissue that's targeted. And basically, you target it by stereotactically focusing radiation onto that small volume of tissue. And in this particular case, this picture doesn't really show much justice to this image here. But essentially, you have a catheter in the low right atrium, and you have another pole that's in the septum. And you're pacing from the low right atrium, and you can see that there's block along this region, and the impulse has to go around, so much so that you have delayed conduction. So this is demonstrating that you can actually block the cavo-tricuspid isthmus using radiation therapy. And this particular series actually did ablations in the AV node as well. This is another series from the Mayo Clinic looking at the use of radiation therapy targeting the AV node in pigs. They use multiple dose variations, and they use 25, 40, and 55. And essentially, what you find is that after about 17 weeks after radiation, and that's a long time for this effect to take place, you get complete heart block. So this is sinus rhythm here on the top, and after 17 weeks of radiation, you have complete heart block developing. And these are the histological changes. At 3 months, you get a lot of hemorrhage, inflammatory changes, and some fibrosis. And at 6 months, you have fibrotic tissue replacing active myocardium. This is a sham thing, and this is the radiated things. So this is typically what the radiotherapist sees on their screen. They basically target the organ of interest or the tissue of interest, and multiple beams are focused onto a small volume of tissue. And you basically have the purple areas where you have the maximal intensity of radiation. And as you go further and further out diametrically, you'll find that the dosing falls off very rapidly. So within the first centimeter, you get the maximum dose. And then it falls off by half when you go maybe 5, 7 centimeters. So this is the principle of essentially focused radiotherapy, and you can figure out exactly what the rest of the organs are receiving by using this technique. And the factors governing the effect of experimental models is that they found out that essentially it requires a minimum of 25 grays on the myocardium to have an electrophysiological effect. The mean time to AV block in these porcine models is about 11.2 weeks, so it's some kind of a late effect. They were able to do voltage maps before and after the radiation therapy, and the areas of low voltage after therapy correspond to the targeted treatment volume. So it looks like you're basically hitting the areas of interest. Now, when you talk about non-invasive application of this particular technology, you have to be able to decide exactly where the arrhythmia is coming from. In most cases, patients have already had some kind of invasive procedure. We know where the arrhythmia is coming from. We've mapped out the actual, the area scar and the circuits. This particular system where, if you want to truly make it non-invasive, you have to have some kind of non-invasive way of deciding exactly where this arrhythmia is coming from. And in this particular system, this is now the ECGI mapping system that was originally organized and studied by Yoram Rudi, and it's now owned by Medtronic, and I think it costs another $200,000 to buy. Most of us don't have access to this system, but it's able to kind of tell you exactly whereabouts in the cardiac tissue your area of interest is. So this is a 256 electrode vest. And then these have radiopaque markers, and patients actually have a CT or MRI scan. And by computing the activation patterns on the anatomy, you're able to come up with an activation map that tells you exactly what's going on. So here is somebody with an ectopic beat. The first VT beat is actually here. And you can see the activation starts, this is the left lateral view, in the low left ventricular lateral wall. That ectopic beat then triggers monomorphic ventricular tachycardia, which can then be seen to be originating at a slightly higher level. So this is the technique that the Washington group used for totally non-invasive ablation of ventricular tachycardia. Like I said, most of us don't actually have access to this particular technology, and we have been primarily using a Cardo map or some kind of predetermined imaging system. Now, the workflow for cardiac SBRT is essentially identifying an area of interest in the myocardium, either by using an MRI, PET scan, nuclear scan, or ECGI. And like I said, most of us have some kind of electroanatomical voltage or activation map from a prior EP study. And then, once you have this imaging study, we then create 2D areas in axial, sagittal, and coronal planes and combine this to form a 3D target volume. You then prescribe a dose. Typically, it's about 25 grays. And then radiation trajectories are designed to concentrate energy delivery to target within 1 centimeter with a fall off of half value within about 7 to 9 millimeters. So essentially, you get your maximum effect within about 1 centimeter where your target is. Patients are immobilized. And in this particular case, this is an ECGI map of activation, and the red area shows earliest activation. And you can take a volume of tissue that encompasses the first 10 to 20 milliseconds of your activation. Most of this is epicardial exit site activation. So I'm not sure how good this is when somebody has intramural or an endocardial breakthrough as your primary abnormality. And then you basically draw an area of interest, and then that's where you deliver your therapy. So this is the initial experience, early experience with SBRT for VT from Philip Kuklitsch that he published in New England Journal of Medicine last year. There are 5 patients here, and all of these patients had a large number of VT episodes pre-procedure. They had a blanking period of a month, and after that 1 month period, you can see there's a dramatic drop-off in the incidence of VT. One patient in this group died from a stroke. That patient actually had atrial fibrillation. It's possible it's all related to some kind of an anticoagulation issue. But this was very impressive. They then went on to do the Encore VT study, where they actually included those 5 patients and then added another 14 patients. 17 of these patients had VT, and 2 had PVCs with a low ejection fraction. Patients had to be greater than 18 years to enter into the study and have at least more than three or more episodes of sustained monomorphic VT. They excluded patients with VF and polymorphic VT. And they excluded patients with inotropic supports or LVADs. And these are the results, again, very impressive. Each of these is actually a patient in that study. And you can see this is the frequency or the number of VT episodes pre-ablation, and post-ablation, there's a dramatic reduction in VT episodes. This is the use of antiarrhythmic drugs at baseline, and you can see this is class 1, green, class 3 in purple, amiodarone low dose and amiodarone high dose. And you can see a lot of patients could actually reduce the dose of our amiodarone. So these results are clearly very, very interesting and encouraging. But you must remember that there's only a 6-month follow-up in this group of patients. 5 patients developed radiation pneumonitis, all of which responded to steroid therapy. 5 patients had pericardial effusions of unknown etiology. We don't quite know why these patients developed. One of them actually had an epicardial ablation prior to radiation therapy. All of them were treated conservatively. Nobody needed surgery or pericardiocentesis. There was no acute toxicity seen. And also of importance, a lot of these patients have defibrillators in place, and it does not appear to affect your defibrillator function. So it does look like, this is a very promising therapy. This is a patient that we had, 45 years of age. who had a left circumflex occlusion, ejection fraction 25 to 30%, and recurrent monomorphic VT. We took him to the lab, and with extensive ablation, we were able to settle his VT down. But we decided to take him to the take his images down to radiation therapy and try to model, see if we can actually find a volume that we can treat. And what we wanted to do was to find out what the collateral dosing was. What are the other structures close by? Could we kind of figure out exactly what kind of doses the coronary artery would receive, for example? And so what we did is this patient had a prior CT scan, and we decided this was the volume of tissue that needed to be treated. And you can see this is quite substantial. There's a lot of volume of tissue that needs to be treated. If you just went for the exit site alone, you will probably find that you can treat a smaller volume. But the exit site may be okay for 1 VT. Most of these scars can support 3 and 4 and 5 VTs. So it's likely that you have multiple exit sites for more than 1 VT. And this was the dose calculation. The prescribed dose is 25, and the D max for the basal LV was about 27 grays, and the mean dose is about 25. The esophagus received about 13 grays, or would receive 13 grays. 15.4 is the dose of concern. Below 15.4 is considered to be benign and okay. The lungs receive very little radiation therapy, or collateral radiation. Spinal cord, again, receives very little. The coronary arteries, on the other hand, especially the circumflex vessel in this particular patient, receives a pretty high dose of 27 grays. Now, in this particular patient, it probably doesn't matter because he's got an occluded circumflex, has an infarct in that zone. But you take somebody with a non-ischemic cardiomyopathy who does not have an infarct, this is a cause for concern in the long term. So how does SBRT compare with catheter ablation? Well, catheter ablation is clearly invasive. SBRT can be non-invasive if the substrate can be identified from imaging and body surface mapping. Radiofrequency, cryoenergy, and ultrasound, etc. The energy source is very different here. This one uses ionizing radiations. The mechanism of tissue destruction is acute coagulation necrosis with loss of viability and replacement of fibrosis. Whereas in this particular situation with SBRT, we don't quite know exactly how you get tissue destruction. There's probably gradual cell apoptosis and possibly ischemic injury. It's interesting that although it takes several weeks for the radiotherapy to actually have an effect, a lot of patients have noticed a dramatic drop in VT incidence soon after radiation therapy, and this may be related to the fact that these patients have significant edema of the tissue that stops them from having recurrent VT. The time to effect is immediate in catheter ablation within weeks or months for SBRT. There's a large experience with catheter ablation. There's very limited experience in off-target delivery can risk collateral damage. And most importantly, we don't clearly know what the long-term effects from radiation of the surrounding tissue is going to be. But clearly, VT remains a major problem, and stereotactic radiotherapy offers an alternative means of ablation in these patients who are having recurrent, repeated episodes of VT and getting ICD shocks. The mechanism and long-term effects are not fully understood. And I should emphasize that SBRT at this point should be considered investigational. And if you want to enter patients into this protocol, it's best to enter them into an ongoing clinical trial so we can get more information about this. Most importantly, the long-term side effects of this particular methodology for treating VT. Thank you.
Thank you. We move forward to the next talk by Dr. Gepstein, and it's entitled Optogenetics for the Treatment of Cardiac Arrhythmias.
Okay, thank you very much for the invitation to beautiful Barcelona. What I'll try to do today is to share with you a little bit our results about a new methodology that comes from basic science for the study and treatment of cardiac arrhythmia. And we'll share a number of technologies. First, we'll talk about optogenetic actuators, which are light-sensitive proteins that are also called opsins, which are ion channels or pump that respond to light by changing their activity, therefore have the potential to modulate excitable properties of excitable tissues. We'll also discuss some optogenetic sensors. These are proteins that act oppositely, meaning that they change their conformation based on changes in the electrical activities of tissues and thereby emit different light or fluorescence, and we can use them as sensors. The third technology I would like to introduce to you is the technology introduced by this guy, Shinya Yamanaka, the induced pluripotent stem cell technology. This is a technology by which adult somatic cells, such as fibroblasts or blood cells taken from a patient, can be reprogrammed to generate cells that are called induced pluripotent stem cells that resemble the fertilized egg or embryonic stem cells. These cells can then be coaxed to differentiate to generate any cell type, liver cells, brain cells, and heart cells, which are unique to that specific patient, and therefore can be used for autologous cell transplantation therapies, to generate patient-specific disease models, and as for drug screening applications. Now, this turned to be a robust technology. We now routinely take cells from patients, reprogram them to make iPS cells, and then use lessons from embryology to guide their differentiation to generate heart cells, as you can see here, so you can make patient-specific heart cells in a dish. One obvious application is the potential of using such cells for regenerative medicine to treat heart failure, for example. And we've been shown the ability to derive such cells from heart failure patients to make the appropriate heart cells. These heart cells can integrate with existing heart tissue and be transplanted to animals' model of heart failure. We anticipate to start clinical trials using such an approach within the next 3-4 years. We can also use these cells not only as isolated cells, but rather as a tissue engineering concept in which we create tissues by comparing such heart cells with polymers that act as scaffolds. This is an example of a collaboration we have with Wolfram Zimmermann from Germany, in which we take a collagen, mix it with cardiomyocytes derived, for example, from pluripotent stem cells or any other cell type. You put it on a stretcher device. This is like mechanical training of the cells, like you go to work out and your muscle hypertrophy. The same thing happens to this tissue, and we end up generating a tissue that starts to contract and can generate a very nice force, as you can see here. We've done this with different iPS models, and now we have very nice calamari-looking like structures that contract. Okay, so we can make tissues also, and in this specific project, we're using them as models of heart tissue for several applications. For example, one application is to use this technology to learn about inherited cardiac disorders, such as inherited cardiomyopathies or inherited arrhythmogenic disorders. For example, if you have a patient with an familial genetic disorder, one can take cells from these patients, generate induced pluripotent stem cells from that patient, differentiate them into heart cells, and the hypothesis is that these heart cells would portray the patient's specific properties. To test this hypothesis, we did these models in a number of inherited arrhythmias. I'll show you one example briefly. This is a young patient that came to us after she had cardiac arrest in the street. We diagnosed the family as having a long QT syndrome, and we identified a point mutation in the KCNH2 gene responsible for the long QT type 2. We then took some cells from the patient, reprogrammed them to make iPS cells, and then differentiate them into heart cells and studied the heart cells with the use of patch clamp. And as you can see, in contrast to the patient, in contrast to a healthy control iPS-derived cardiomyocytes, the patient cardiomyocyte had a prolonged action potential duration, as expected from the long QT syndrome. And not only that, they recapitulated the arrhythmogenic phenotype with some of the cells developing early after depolarization, trigger beats, and a minority of the cells also repeated trigger beats. We can also use this technology to test the effects of drugs. We know one of the important issues in drug development is safety pharmacology. We know that the most important reason why a drug is withdrawn from the market, for example, after being approved, that it can prolong QT and generate this drug-induced torsade de poids. And interestingly, about 50% of all molecules that are being developed by pharma have this kind of effect. One of the problems when you develop drugs in general, you don't study them on human cells. So we suggested a few years ago, maybe we can use the human cells that we are producing as a screening tool to study the effects of drugs. And indeed, when you give a drug that blocks the relevant potassium channel, it prolongs the action potential and creates an arrhythmogenic phenotype. And you can do the same for drugs known to prolong QT, such as sotalol or cisapride, which was withdrawn from the market due to a pro-arrhythmic effect. Now, for all of you that are doing cellular electrophysiology, you know that patch clamp is not a very high throughput method. You cannot use it to test thousands and tens of thousands of compounds. So we're developing optogenetic sensors that will allow us to do this in a high throughput manner and also continuously along a long time. The idea is to use proteins that can act as sensor. In this case, we're using genetically encoded voltage integrator, specifically a protein called ArcLight, which is comprised of a voltage sensor taken from this organism, which was hybrid with a circular GFP. So you can take the DNA encoding for this protein, express it in our human heart cells, and now you have human cardiomyocytes that change their fluorescence based on the membrane potential, membrane voltage. So you can now quantify this and get a non-invasive, high-throughput way to look at action potential morphology in the cell. Now you can screen many QT prolonging agents, for example, and you can do this also with our long QT line. Notice that now we can look at many, many cells and examine many, many phenomena. We can also do this not only for voltage, but also calcium to look at parameters affecting calcium handling. This is a different reporter called GCAMP, which changes in fluorescence based on the levels of intracellular calcium. Okay, so we talked about looking at the cellular activity of the cells, either as a model for arrhythmias or for drug testing. But we all know that most arrhythmias cannot be generated in single cells in the heart. You require a tissue because most of them are reentrant in nature. So we are moving more and more to generating tissue models of arrhythmias. To this end, we are generating 2D, as in this case, or 3D models. Here we took a few million heart cells, human heart cells, plated them as large cardiac cell sheets, and we are forming like a small tissue in which you can see the propagation both macroscopically and microscopically. You can see how the mechanical force propagates. You can now use our optogenetic sensors or voltage-sensitive dyes and a unique optical mapping system. This is for activation mapping of these sheets. And you can actually generate this propagation map that tells us how electric activity propagates within these small heart sheets. We can do it, as I said, using both the ArcLight, which allows us long-term, continuous for week, looking at activation and both repolarization, as well as voltage-sensitive dyes. Now you can, similar to what you do in patients, you can try to induce arrhythmias in this model, in this small heart-like tissue. By doing program electrical stimulation, you can induce reentry activity, as you can see here, something that looks like a rotor. Okay, so you can induce rotors in these tissues, and you can use these optical mapping procedures to look at the rotors we generated. We do it both in normal tissue and in tissue from genetic disorders, for example, the short QT syndrome. So you can see how acquired or genetic disorders can affect baseline electrical properties. You can do how arrhythmias are initiated. Here we are pacing rapidly, and you can see that the development of a rotor within this tissue. We can see what are the parameters of the rotors that makes it sustain and not terminate, and won't terminate. And we can see how it breaks to multiple wavelets, such as occurs, for example, during fibrillation. So we have a way to look at these processes in these human tissues. We can also test, for example, how the drugs that prolong QT at the single cell level, how they cause arrhythmias at the tissue level. Here, for example, we treated these sheets with high-dose dofetilide, and we noted that while in some cases the colors represent voltage, early after depolarization may develop, but they cannot propagate because they're surrounding around them by cells that are already excitable because there's less dispersion of repolarization. In some cases, these early after depolarization meet refractory period, excitable period tissue next to it. So if it's all surrounding it, like here, as you see, the red will be surrounded by purple, then a trigger beat may start, which activates the tissue, but there's no unidirectional block, so reentry cannot be formed. But in contrast, if an EAD forms at the area of dispersion of repolarization, in which one area there is excitability, the purple, and in other areas it's blocked, you can see that a figure of H reentry develops, which eventually leads to the development of reentry activity. So this teaches us how we can develop these arrhythmias at the tissue level. Shifting gears, we now move to the way we could actually modulate the activity of the tissues with lights, with optogenetics. And it all started when scientists realized that algae move away or toward lights because of the presence of light-sensitive proteins. The prototype is channel rhodopsin 2, which is a non-selective cationic channel, mainly allowing to pass sodium channels. And this channel opens following activation to blue light. So scientists now can express these proteins, algae proteins, in excitable tissues, and most of the work was done in the brain, in animals. So now you can actually modulate the electrical activity of the brain by light. And this is a famous movie. This mouse has channel rhodopsin in its brain, and now you shine blue light, and the mouse starts to walk in circles. Why does he walk in circles? Because the illumination is only given on one part of the motor cortex, so only one side. So this really transformed neuroscience because now you can really activate or suppress specific neurons and learn about the network properties. So we wanted to take this to the heart, and how do you deliver these light-sensitive proteins in the heart? We're using two methods. Either we're using gene therapy to deliver the gene encoding for these different light-sensitive proteins directly to cardiomyocytes, or we are expressing them in another cell, such as fibroblasts, and after transplantation, these fibroblasts connect with the cardiomyocytes, and they can affect their electrical activity through electrotonic currents. So when you express channel rhodopsin in cells, you can see that at darkness we cannot elicit any current, but when you illuminate with blue light, you can generate robust inward current through these channels. The first step was to try to use it as a pacemaker. So we did a co-culture of fibroblasts expressing channel rhodopsin with cardiomyocytes, and we recorded electrical activity from these cultures. This is baseline activity, and then we shined flashes of blue light at different frequencies, and you can see that we can pace these neonatal rat heart cells with light. We then moved to our cardiac cell sheets model. Again, we introduced cells expressing channel rhodopsin here. When you look at darkness, the pacemaker, spontaneous pacemaker, was here. In contrast, when we now shine light, the pacemaker location shifted to where our site is. So spontaneous activity, when we shine light, we generate a pacemaker in this tissue. So we then moved to the entire heart. We wanted to see whether we can do this. To this end, we delivered, using adenoviruses, the transgene encoding for channel rhodopsin to the apex of the rat heart or the rat ventricle. So now cells in the apex express this channel rhodopsin protein. We then took out the heart a week later, and using the Langendorf model, studied the heart. You can see that the heart beats happily outside the body. We will then shine flashes of blue light. I'm afraid this computer is a bit too slow, but you can see that every flash of blue light captures and paces the ventricle. Let's give it another try to see if it works. So the idea is that the blue light opens the channels, sodium channels rush in, they create depolarization, generating an action potential, and this action potential then propagates and activates the ventricle. I'm afraid this computer is a bit too slow to show this nicely. We then did it at different rates, so we can pace the heart with different rates with no problem, and we can do it also when the heart is still in the chest of the animal. Again, the heart is beating happily. We will now shine flashes of blue light, and we can see that we pace the heart, we stop, it goes back to normal rhythm. Okay, can we do more than just pace the heart? For example, what can we do? For example, we can generate an optogenetic-based resynchronization therapy. You all know that one of the limitations of current methods for CRT is that we are limited to the number of electrodes that we're using, namely 2, and where they are located. But there's no reason why not, for example, to try to activate the ventricle from several sites. And light, because of the ability to be diffused, it could potentially do this. So to test this, we did this initially in the culture. So this is light stimulation at one point, and this is diffuse stimulation of the entire culture, and of course, this results in a much shorter activation time than a point stimulation. Okay, I'll skip to this. We then went to the in vivo setting. So first we wanted to imitate biventricular pacing. So we injected our channel rhodopsin to 2 sites, here and here. We then use light to activate either one site. So you see when we shine light on this point, activation starts at this specific area. When we shine light at this site, the activation shifts and starts from this position. And when you shine lights on both sides, we get activation coming from 2 sites. But we are not limited to 2 sites. We can do to any number of sites. Here, for example, in this study, we did either in 3 or 4 sites. Here you see 3 sites in the ventricle. So first we look how sinus rhythm looks. So sinus rhythm in optical mapping is very fast. The entire left ventricle is activated very fast. To simulate the synchrony, we pace the right ventricle to simulate left bundle branch block. And look, now activation takes longer to activate the ventricles. And we shine light on all our 3 sites. Activation is again synchronously from these 3 sites. And if we calculate this, sinus rhythm total activation time of the ventricle is very fast. When we simulate left bundle branch block by pacing the right ventricle, we get a much larger activation time of the left ventricle. But when we activate the ventricle simultaneously from multiple sites using optogenetics therapy, we can reduce it to the timing of sinus rhythm. So until now, we identify where to activate the ventricle by where we put the proteins. But you can put the proteins diffusely and generate any activation sequences you want by just generating a light pattern to where you want. So we're using a device called DMD with multiple mirrors that allows us to actually generate and activate the cardiac tissue from any point with any pattern and to shift it from one point to another. Here, for example, we're doing, this is spontaneous activation. Here we're activating from a right circle, as you can see here. Here we're activating simultaneously from 4 circles. Here we can use a rectangular activation. And this is diffuse activation of the entire. So you can actually generate any activation pattern that you want. Can you do the opposite? Can you also stop electrical activity? We only talked about generating electrical activity. So the idea whether you can suppress, you can use alternative light-sensitive proteins. Here, for example, halorodopsin is a chloride pump that following activation by light introduced negative ions into the heart, and this is into the cell. And as you can see in this worm, it can freezes its movement when activating this channel. Again, the worm swims. You activate halorodopsin, it freezes its activity. So we tried this idea to suppress activity by producing hyperpolarization in cardiomyocytes. This is in a culture. Here we didn't use allorodopsin, but archorodopsin, which is a proton pump that uses protons to exit the cell and therefore also results in hyperpolarization. And again, we can suppress the activity of these cells. An alternative approach is to perform continuous depolarization with channelrhodopsin. So we have actually two ways of silencing cardiomyocytes, either using something that hyperpolarizes the membrane continuously, like the archorodopsin, and now we are using a more modern, a more new version of a chloride chloride channel, ACR2. And you can see that we can stop electrical activity by inducing continuous hyperpolarization. Or you can use channelrhodopsin, and by generating continuous depolarization, sodium channels are inactivated, you can also stop the activity of the cells. So can we terminate arrhythmia? So we shifted to our arrhythmia rotor models in sheets of human cardiomyocytes. Now we do the entire program electrical stimulation with light. So we do optogenetic program stimulation, and we can induce rotors, as you can see here. And now we'll try to eliminate rotor. This is a rotor. We shine diffuse light, and it goes back to normal rhythm. Can we do this in an animal? So this is my last slide. So we generated a VF model in rats by inducing cardiac an infarct. 4 weeks later, we took out the heart. When we induced the infarct, we also delivered the light-sensitive proteins into the ventricle, primarily in the border zone of the infarct. So we now study it with Langendorf approach. We now do program electrical stimulation. You see the heart is in sinus rhythm. We'll try to induce VT-VF. You can see now it's really in a rapid ventricular arrhythmia, as you can see here. We'll now shine diffuse light and try to convert it to sinus rhythm, and it goes back to sinus rhythm. And with that, I would like to end and thank the people in my lab that did this work, and thank you for your attention.